Good morning. Sorry for a little delay. It took me an hour to get here on multiple alternate routes. It is my great pleasure. Sorry about my voice as well. I'm about to lose my voice. So it is a great pleasure for me to introduce today's virtual invited lecturer, Dr. Hugh Hemmings. Dr. Hugh Hemmings is a Joseph Artuzio professor and chair in the Department of Anesthesiology of Cornell University, and he's also senior associate dean for research at Cornell Medical Center. Dr. Hemmings earned his bachelor's degree at Yale College, went on to get his PhD at Yale Graduate School, and then his medical degree at Yale School of Medicine. So you can say that the only thing Dr. Hemmings didn't do at Yale was his kindergarten, right? Upon completing his MD PhD studies, actually, he went on to do residency in anesthesiology. He did at Mass General, and then his fellowship in cardiac anesthesia at Cornell, where he's been for over 25 years. What is really remarkable about Dr. Hemmings is that when he was doing his PhD studies, actually his work became part of the Nobel Prize that his mentor got in 2000, Dr. Paul Greengard. How many of us can claim to have done that? That's pretty amazing. Dr. Hemmings is internationally known neuropharmacologist who I've known for over 20 years. He actually is very interested in studying the properties of different anesthetics and their effects on, I'm really losing my voice, I'm so sorry, and their effects on neuronal transmission and neuronal signaling. His research has been supported by the NIH for over 2 decades, and he has been instrumental in many primary works that we are all familiar with now. Dr. Hemmings is also very involved not only nationally but internationally as well, and he is the editor-in-chief at British Journal of Anesthesiology. This is where I got to know him quite well when I got to be the member of the editorial board. He's published over 120 publications in peer-reviewed journals and also is the author of several books and editor of several books. Now, when you think about textbooks having a half-life of a cottage cheese, his actually textbook is going for a second edition that is going to come out in 2019. So, without further ado, let me welcome Dr. Hugh Hemmings. Thank you.
Thank you, Vesna. I also have a cold, so I have the East Coast version. But thank you very much for the opportunity to visit. And so I did my PhD in pharmacology, so I'm a bit of a pharmacology nerd, I guess, is probably the best word. And so I'm going to give this talk today, which is really sort of a hodgepodge of different pharmacological vignettes. But it's centered around antidotes and anesthesia. So my conflicts are research funding from NIH. I'm not talking about that today. Editor-in-chief of the British Journal, which I am a bit partial to papers that are published there, so you may see some of those. I'm on the advisory board to Elsevier for Clinical Key, but that doesn't have anything to do with this. And also our book is published by them, so keep your eyes out for that next year. So I'm going to talk about poisons and antidotes. And it's kind of odd to be talking about poisons when you're trying to make people better. But I think it's an interesting way to look at what we do. I mean, the drugs we use are all very potentially poisons. They have very low therapeutic indices. And actually, I was telling my wife I was going to give this talk about antidotes, and she goes, yeah, I had one of my friends, my parents' friends growing up was an anesthesiologist, and he used to tell me that he made a living poisoning people, but then bringing them back. So in a way, that's apt. So a poison is a substance that somehow interferes or injures or kills an organism, and we're all familiar with cyanide's kind of the classic poison. There are also now fragrances and rock bands that are called poison. A toxin, to distinguish from a poison, is a poison that's produced by organisms in nature. And the one that I think of often is tetrodotoxin. So it's a naturally occurring compound that is a poison, but because it's produced by an organism, it's known as a toxin. And venoms are toxins that are injected by an organism through a bite or a sting, like a bee. I was reading an article yesterday about new therapies for pain, and one of the organisms that's being explored among many is the centipede, and it had a picture of the Chinese centipede, which totally freaked me out because I got stung by a Hawaiian centipede in my bed one night in Hawaii, so that was not a pretty sight, I have to say. So they're looking at those toxins as analgesics. So a lot of good drugs have actually come from venoms. And just to distinguish, a drug is a substance that has a physiological effect. It's usually desired to treat some condition. So I'm going to do a little history. I want to tell you about my hero, Paracelsus. And Paracelsus is the father of toxicology. And he's famous for this saying, I'm sure you've heard. Alle Dinge sind Gift und nicht ist ohne Gift. Allein die Dosis macht, dass ein Ding kein Gift ist. So everything is a poison, and only the dose makes the difference. And we all know that. I mean, I think from the first day you pick up a syringe of a potent anesthetic or opioid, you're taught to give it incrementally. Small doses, observe the effect, and then titrate accordingly. So Paracelsus figured this out. He was one of the most influential medical scientists. I guess scientist is fair. His job description at the bottom there is actually fascinating. He was a Renaissance physician, botanist, alchemist, astrologer, and occultist. So he kind of covered the range. He unfortunately died quite young, at 48. And here are a couple of his quotes. I have not been ashamed to learn from tramps, butchers, and barbers. This led him to reject much of university-taught medicine. So he actually was one of the first to come out against Galen's four humors. And he argued that the body was like a chemical system, which, when you think about it from that time, was pretty far ahead of his time. He also was the first to advocate using chemicals in medicine, so drugs. So he was a pharmacologist, really. And he actually noted that oil of vitriol, which is diethyl ether, he calls it oil of vitriol because you get it by mixing ethanol and sulfuric acid, was able to produce analgesia. So he didn't discover anesthesia per se, but he discovered the analgesic effects of ether, which is remarkable. So he had some bad habits. He never went anywhere without his sword. He drank a lot, and he died in a tavern brawl in Salzburg, Austria, where he's buried, and there's a really nice monument there. And Salzburg has memorialized him by naming a private university after him, Paracelsus. So this is a book that came out. Disclaimer, I haven't read it. It doesn't seem like any kind of really deep book. All medicines are poison, making your way through the medical minefield. And basically what this book does, it appears to me, is paraphrase Paracelsus. He quoted that it is the dose that makes the poison. So what is an antidote? And that's what I'm going to focus on today. Antidote is an agent that counteracts a poison. And whether we're aware of it or not, I mean, I wasn't really taught that a lot of the drugs we were using were necessarily antidotes, but I think that is true. So I want to just review the sort of pharmacological classification of antidotes, and then I'm going to pick a few examples from anesthesia that have been, that are kind of changing as we sit here today. So the first type of antidote, and most of them are physiological antidotes, are those that counteract the effects by producing the opposing effect. And I'll give you an example. A chemical antidote actually changes the chemical nature of the poison and to create a harmless substance. The complex formation is an antidote that binds or complexes with the poison to inactivate it. And a mechanical antidote, which I'm not going to talk about, is one that prevents absorption of the poison. So here are some of the ones that we're all familiar with that have been around for a while. I've highlighted in red a couple that I'm going to talk about. So those that involve the cholinergic transmission system. But, there's flumazenil for benzodiazepines, there's naloxone for opioids, and there's a number here. So here's a couple examples for the first three, for all four classes of antidotes. The physiological antidote, neostigmine glycopyrrolate, which we're all familiar with. Chemical antidote, pralidoxime for organophosphate poisoning, which fortunately we're not that familiar with, but we could be. And sugammadex for complex formation. And then but for completeness, activated charcoal would be a mechanical antidote. So these are the structures of neostigmine and glycopyrrolate, and they're critical. They're drugs that interact with the cholinergic synaptic transmission or neuromuscular transmission. And acetylcholine is, as you know, critical to muscle control, but also to the autonomic nervous system, also in the central nervous system. And other organisms that aren't so friendly to us have figured that out. And so a lot of drugs and toxins actually target the cholinergic system. Because of its widespread involvement in many physiological processes, any drug that interferes with cholinergic transmission has pleiotropic or multiple effects. So here's a diagram. Acetylcholine is a classic neurotransmitter, so it's taken up into the presynaptic, synthesized in the presynaptic terminal, stored in vesicles, released on stimulation, enters the synaptic cleft, and then binds to the postsynaptic receptor to elicit a response. So there are two major classes of postsynaptic receptors, the muscarinic and nicotinic. And if you overactivate the cholinergic system, and that's what's shown in the diagram below, you get paralysis, or if you block it, you get paralysis. We'll talk about that in a minute. And the muscarinic system, you get autonomic effects. Come back to that in a minute. So a common poison that we use is a neuromuscular blocking agent. So this is a drug that blocks cholinergic transmission, and it blocks the effects of acetylcholine on the postsynaptic receptor. The antidote we use, the physiological antidote, is to administer an inhibitor of acetylcholinesterase, and that's shown in the diagram below. It's sort of conceived as having two binding sites. There's an anionic site that binds the quaternary ammonium, and then there's the serine, catalytic serine, which is a hydrolytic serine that cleaves the acetate group from the choline group to inactivate acetylcholine. So if you block acetylcholinesterase, acetylcholine accumulates, and it can overcome the block produced by the neuromuscular blocking drug, which is competitive block. Now, some of the reversible anticholinesterases are shown here. The classic one is neostigmine. Adrophonium is a shorter-acting version. Pyridostigmine, rarely used in anesthesia, but used for neurology to treat myasthenia gravis. And then physostigmine. The difference with physostigmine is it doesn't have the quaternary ammonium, so it can enter the CNS. And back in the dark ages, was sometimes given to people who were delirious after anesthesia and surgery. But the most common one is neostigmine, it actually reacts with that serine and forms a short-acting covalent intermediate. So these are carbamates, and they can block the activity of the cholinesterase like that. But the problem with cholinesterase drugs is you have to give another drug. So if you block cholinesterase, acetylcholine increases not just in the cholinergic neuromuscular synapse, but also in other cholinergic synapses, including those involved in the autonomic nervous system, and that can cause serious side effects that we're all aware of, so we have to give a third drug. So if you want to block or relax muscles, you've got to give a neuromuscular blocker, you've got to give a cholinesterase inhibitor, and an antimuscarinic drug. And when you think about it, that is a really stupid way to do things, but you know, that's kind of how things have evolved. And I'll come back to that. So chemical antidotes. So these are antidotes that actually inactivate the poison and change the chemical nature. And it's probably the best example, or one of them, is pralidoxime, used to reverse organophosphate poisoning. This was used a lot in the Gulf Wars because of the nerve gas, and this is used to treat the nerve gas poisoning. It consists of pralidoxime and atropine, the antimuscarinic drug. It's used to as an antidote for organophosphate nerve gases, and here's a bunch of them. It's amazing how much effort people put into figuring out good ways to kill people. Probably the most famous one is sarin, and that was the drug, the poison used by Assad in Syria, but also in other places. And then there are the newer ones, the Novichok poisons, which are also organophosphates that have been developed by Russia and were recently involved in the murder in the UK. So what happens with an irreversible cholinesterase inhibitor, where you get all the side effects that we would give glycopyrrolate to antagonize? Mostly it's hypersecretion, so runny nose, watery eyes, blurred vision, coughing, nausea, and then the CNS symptoms of confusion, weakness from the neuromuscular effects. So what happens and here's the slide I showed before, when you block cholinesterase, shown in the postsynaptic side there, you get very high concentrations of synaptic acetylcholine, and that causes weakness and fasciculations because of overactivation. You get a depolarization block of the muscle. The muscarinic sites, salivation, lacrimation, urination, diaphoresis, GI upset, and emesis. Also bronchoconstriction and bronchorrhea, and those are the killer symptoms. So if you saw the pictures of the victims in Syria, they often were foaming at the mouth and dying from hypoxia. So pralidoxime, and this shows sarin. So the organophosphates, they actually phosphorylate that catalytic serine in the active site of cholinesterase, and that irreversibly, in quotes, inactivates the cholinesterase. What pralidoxime can do is to react with that phosphorylated serine to remove the serine and reactivate the cholinesterase, and that's how it is able to reduce synaptic acetylcholine and serve as an antidote for these nerve gases. So now let me talk about some novel antidotes, things that have come on the scene in the last 10, 15 years that are relevant to anesthesiology. And the first one I'll discuss is use of lipid emulsion to treat local anesthetic toxicity. So if you think of local anesthetic as the poison here, which it is if it gets into the wrong place, we've recently been using intralipid, a lipid emulsion, to treat the toxicity. The mechanism is a little bit controversial, but I think it's becoming clear that it's more of a physiological mechanism rather than a sequestration mechanism, which is kind of intuitively what makes sense. So local anesthetics block sodium channels, voltage-gated sodium channels. And that's how they block nerve impulses. But they have multiple off-target effects. And the main one that we're concerned about with regional anesthesia, well, the two main ones, you get if it gets too high in the CNS, you get hyperexcitability, seizures. If it gets too high in the heart, you get cardiovascular collapse and cardiac arrest. So the field of regional anesthesia has really evolved now to precisely place local anesthetics to avoid a lot of this toxicity, but occasionally it can still happen. When I trained as a resident, again in the dark ages, before ultrasound-guided regional anesthesia, it was all volume blocks. You just put in a lot, and you just hoped that, there was enough to block the nerve. Of course, I didn't get good training in regional anesthesia because I trained at the Massachusetts General Hospital, and that's what they would always say. Why do you think they call it the General Hospital? Everybody got general anesthesia. I think that's changed. So there are a bunch of side effects, as I mentioned. The teaching used to be that the CNS side effects were the early warning, so that if you started seeing some of these symptoms, agitation, confusion, muscle twitching, definitely seizure, you were getting into toxic levels. And that was thought to be sort of the protector for toxicity, early warning. Eventually you get depression, CNS depression, and you also get some of these sensory symptoms sometimes early. The problem is the CNS signs can occur as only in about 50%, and they may be very subtle or absent. So if you're not looking for it, you may miss it. Excuse me. Now the cardiovascular signs are the ones that kill usually, and they can occur quite late. So as the drug is absorbed and the levels increase, and the effects on the heart are interesting. They're initially hyperdynamic, so hypertension, tachycardia, arrhythmias, and then that progresses to hypotension, bradycardia, asystole, and arrhythmias. All not good things. So over the years, over the last couple decades, the intralipid was used, I think, empirically first, and there was some animal data to support its use to treat local anesthetic toxicity. And ASRA and other bodies have taken this up and have changed their guidelines for treating local anesthetic toxicity. In addition to using intralipid, which, there's really not super strong data in humans, mostly anecdotal, the other thing that's become clear is one of the things that can really cause bad outcomes is the hypoxia. So if you have the heart, which is being poisoned by lidocaine, you want to oxygenate as quickly as possible. So hence the emphasis on intubating early and giving 100% oxygen. Not using propofol to treat the seizures. And low doses of epinephrine. So here's the dose for intralipid. As I mentioned, it's low quality evidence, but when you have a patient who's in cardiovascular collapse, I think, maybe the best thing you have other than cardiopulmonary bypass. And there are side effects to intralipid, but they're not that common. So the mechanism, as I mentioned before, was initially thought to be sequestration. So the intralipid, being lipid micelles, would just soak up the hydrophobic local anesthetics and cause a redistribution of the local anesthetic from the heart and the brain into the circulation. More recently, it's become clear that there are other mechanisms, and these are probably the most important ones. And the main one seems to be an inotropic effect that's due to activation of a voltage-gated calcium channels and a G protein coupled receptor, GPCR40. And I'll show you that in just a second, I think. So this paper came out this year, which showed that this G protein coupled receptor 40 actually mediates the lipid emulsion-induced cardioprotection in rat models of local anesthetic toxicity using bupivacaine, and they could, knock down this receptor and lose the cardioprotective effect. So I think that's quite interesting, and it's counterintuitive. It's not a sequestration effect, but rather a physiological receptor-mediated effect. So let's move on to the cholinergic system. We already talked a little bit about that with nerve gas. So ways to reverse neuromuscular blockers. So using a combination of neostigmine and glycopyrrolate, not the cleanest way. So there are some more options on the horizon, and Sugamidex is now available, and that works by a unique mechanism. So there's some problems with cholinesterase inhibitors. First of all, they can only reverse relatively shallow levels of block, so you need a train-to-4 ratio of greater than 0.4 to give them. As I mentioned, they're non-selective, so acetylcholine goes up everywhere, and you need a third drug, antimuscarinic drug. And there's a ceiling effect, and it's slow. So Sugamidex encapsulates free steroid neuromuscular blockers and can reduce the effect site concentration in the synapse and cause reversal. It has some side effects. I'll mention a couple more, but one is that it binds oral contraceptives, so that's an issue. And you need to be aware of that with young females of reproductive age. So here's how Sugamidex works. It's a cyclodextrin, which is a cyclic compound that's like a donut that binds rocuronium. There are various cyclodextrins that are designed to sequester different types of drugs. So it's hydrophobic on the inside, and that can bind the steroid tail of rocuronium, vecuronium, and pipicuronium if we had that. So this avoids messing with the cholinergic system. It actually targets the drug directly. So this, I think, is really a good antidote. I mean, it is an antidote. It has reduced residual neuromuscular weakness compared to neostigmine. I guess, there's really very few reasons to use neostigmine other than cost and availability. I mean, it's still, we didn't get this on formulary until last year, and it's still expensive, and pharmacies constantly complaining that we use too much. But I think in a perfect world, that would be it. I was shocked to find this tattoo where someone has tattooed Sugamidex above the Henderson-Hasselbalch equation. Got to have that one. And then also has neostigmine, and above that at the top, I'm not sure which one it is, but it's a benzyl isoquinolinum. So I guess this person is really into neuromuscular block. So here's some data. How fast is Sugamidex compared to neostigmine? So the 6 columns here, the really small columns are the time to reverse from a train-to-4 ratio of 0.7, 0.8, or 0.9 for Sugamidex versus neostigmine. You can see at 0.7 with Sugamidex, 0.7, 8, or 9, with Sugamidex it's minutes. With neostigmine at 0.7, it's half an hour. So, I mean, this is a big, I'm going to show you some data in a minute where people are talking about ways to reverse general anesthesia that may, reduce emergence from 15 minutes to 9 minutes. But, there's a lot more money in this, I think. So it's been shown to have to lead to a reduced incidence of residual neuromuscular block. And here's one paper from Eichermann's group. And they found that they compared neostigmine with Sugamidex for reversing rocuronium after major abdominal surgery. And of those patients who got neostigmine, 43% of them had residual neuromuscular block in the PACU. and the 0 or no patients who got sugammadex had it. So the question is there a downstream benefit? Does this reduce postoperative pulmonary complications, which is kind of the concern that residual neuromuscular block can increase the risk of pulmonary complications? The evidence is evolving there, but it's not definite yet. Your surgeons will be happy. If you combine rocuronium, deep block, with sugammadex, which can rapidly reduce a deep block, you can improve surgery conditions. So deep block provided by an infusion of rocuronium compared to intermediate doses was associated with better operating conditions than standard procedure. Another paper showed that deep block, this systematic review shows that deep neuromuscular block, which is allowed by having the option of using sugammadex at the end, improves surgical space conditions and reduces postoperative pain scores, presumably by giving the surgeons, making it a little easier for the surgeons to work. We would never admit that, but there are some complications with sugammadex, so there's more coming out about hypersensitivity reactions, and here's one. Hypersensitivity in response to sugammadex can occur in healthy subjects without a prior exposure to sugammadex, so including anaphylaxis. This study from Japan showed that incidence of anaphylaxis was 0.059%, which is pretty high. So this is something to look out for. This seems to be less than what's seen in European populations, so this is from Japan. There may be some differences between Asian groups and European groups because the NAP6 study, which was an audit of anaphylaxis in the UK, did not find sugammadex to be a major cause of anaphylaxis. A couple of case reports came out this year which were quite confusing and concerning, and they continue to come out, and that is severe bradycardia and asystole after sugammadex. This paper from the Cleveland Clinic had 2 cases of lap choles, I think, or some sort of laparoscopic surgery where they gave sugammadex and the patient had bradycardia then asystole. And an editorial by Jenny Hunter and Mohammed Naguib sort of suggested that this is something to keep an eye on. So now let's move to another drug that's in development, calibadian, which is not a cyclic compound, but it's similar to sugammadex, and it can create kind of our donut that's not connected, that can sequester not just rocuronium, steroid neuromuscular blockers, but also the benzoyl-isoquinoline neuromuscular blockers. And you can see in the graph on your left that, on your right, that it can reverse both rocuronium and cisatracurium, or shorten time to recovery. Another approach to reversing neuromuscular block by the benzoyl-isoquinoliniums is use of cysteine. So these drugs, as you know, undergo chemical degradation in the body. See the little box there where cysteine reacts with the molecule to inactivate it. So one idea is to give exogenous cysteine to speed this up. And you can see an example of this here, where ganthacurium, which is a benzoyl-isoquinolinium, it's not available in the U.S., but if you let it, it's a pretty short-acting drug. If you just stop the infusion, neuromuscular signaling recovers in about 10 minutes. But if you give exogenous cysteine, 40 seconds. So it's almost immediate reversal. So similar time course to sugammadex. So, and cysteine, as you know, is dirt cheap. So this may be a more economical approach. We'll see. So turning to coagulants, anticoagulants. Let me discuss a couple of new drugs, not so new necessarily, but drugs to reverse anticoagulation, which is another area that we need good antidotes for. Now, a coagulation system is a little complicated. Here's the simplified version. Now, this is a systems biology view, and when I found this, they said that this diagram has been used as evidence for intelligent design. It's so complicated that it couldn't evolve like this. So that's how complicated it is. But you can think of coagulation this way, which is intrinsic pathway, extrinsic pathway, both come into factor 10. Factor 10 converts prothrombin to thrombin. Thrombin converts fibrinogen to fibrin clot. So the direct oral anticoagulants are small molecule inhibitors that inhibit either thrombin or factor 10. So they're downstream, and so by blocking these, you can really knock out coagulation pathway. The type is small down at the bottom, but there, 4 of them are listed here: dabigatran, rivaroxaban, apixaban, and edoxaban. And the way I remember is the ones with the X in the name block factor 10. So, and dabigatran is a direct thrombin inhibitor. So the first antidote developed was to dabigatran. So this is a humanized monoclonal antibody. So this is a recombinant protein that has a high affinity for the direct thrombin inhibitor dabigatran. It then binds dabigatran and then is excreted renally, but it's got a very short half-life and it has to be given by infusion, as it causes immediate reversal of the effect. And as you might imagine, for a recombinant protein, it's expensive. But in certain scenarios, this might be useful. A more recent one that was approved just this year is andexanet alpha, and it's another recombinant protein, also expensive, that is a factor 10 fragment that's been mutated to take away the catalytic activity, and it becomes then a decoy protein. It binds up in this case, it binds factor 10 inhibitors, factor 10A inhibitors. So it can reverse rivaroxaban, apixaban, edoxaban, fondaparinux. It's got a short half-life, again, has to be given by infusion. It was approved by the FDA in May, and it's for use with rivaroxaban and apixaban, and it has had a limited launch, and the plan is to release it more widely in 2019. Because of the unmet clinical need, this drug got U.S. orphan drug and breakthrough therapy designations and went through an accelerated approval pathway, which is kind of interesting. When you look at what the cost for a dose of this might be, it's about $50,000. So, I mean, it'll be there. I can't imagine that we'll use it very often unless the price comes down. So let me finish up by talking about general anesthesia. So I guess the one thing that we could use would be a way to get people to wake up as quickly as their neuromuscular block can be reversed now with Sugamidex. Over the years, we've improved emergence by using shorter acting compounds so that you can facilitate a rapid emergence, but there still may be a need to enhance emergence. And there are a couple of groups that are working on this, and 2 of the compounds, drugs that have been studied in this context are methylphenidate and ketamine. So methylphenidate has been shown by Ken Solt to accelerate emergence from isoflurane in rats, and there's now a clinical trial underway. This is mediated by activating the dopamine system, so it requires D1 receptor activation And you can also stimulate, in rats anyway, you can stimulate the dopaminergic pathway, the ventral tegmental area, using optogenetics or electrical stimulation, and that will reverse the effects of isoflurane. So the animals who have lost their riding reflex will then stand up. It also works for propofol and for sevoflurane anesthesia. Ketamine, shown here in the bottom, is interesting as well. So this this is work from George Mashur in Michigan, where they found that sub-anesthetic doses of ketamine actually accelerated emergence from isoflurane in rats, which was interesting because you give the ketamine and it increases burst suppression. So it seems to increase depth of anesthesia. So the burst suppression ratio increased by 125%, but it shortened emergence time by 44%. And he called this paradoxical emergence. And that's under study now. And I'll finish with, I think I need some coffee. Caffeine. So this paper just came out in Anesthesiology, where they were looking at emergence from isoflurane in humans. This is a human study where they infused saline or caffeine into volunteers anesthetized with isoflurane and measured the amount of time it took them to emerge from isoflurane anesthesia. And they found that when given caffeine, volunteers emerged more quickly. Again, it was about 40%, a 40% effect. So there's a little potpourri of antidotes in anesthesia, which you can think about today when you're poisoning people. So the bottom line is all anesthesia drugs are potent poisons, pretty much. If they weren't, then somebody else would be giving them. So our job is to really do controlled poisoning and make sure that we can reverse these effects. The antidotes are essential, especially to the paralytic drugs, the anticoagulants. The cholinergic system is a target for many of the drugs and toxins, and there's been excellent progress recently in finding new antidotes for neuromuscular blockers, anticoagulants, and local anesthetics. So the concept here is that precise control of anesthetic endpoints like neuromuscular function and breathing and ability to protect the airway will reduce complications, particularly pulmonary complications, and perhaps neurological complications like delirium. So I'll stop there and take any questions if we have. Thank you.
After anesthesia, in that study, you mentioned was 43%. I wonder if you remember those, but there was too much, too little anesthesia. But if too much anesthesia, you guys in different walks.
No, that's a good point. I don't remember the dose, and you have to think about the fact that it's one study, and the investigator probably has some implicit bias anyway, and how you design the study in terms of the reversal with neostigmine could really affect how much residual blood, like when you give it, how deep the patient. I mean, all these are factors which I don't remember for that study, but it just highlights how complicated and fraught reversing with neostigmine is. So unless you're doing quantitative monitoring, which we don't routinely do, you don't know what your train of 4 ratio is. And it's been shown many times that we're very bad at detecting that or determining that with the twitch monitor. So you're reversing, somewhere in the scale. Neostigmine works really, really well when you're, 0.9. But so anyway, I think that's a good point. It may be that the protocol was, biased. But there are other studies that look at residual neuromuscular block. Again, it depends how you detect it. but it's pretty common in the PACU when you look for it. And that's been shown in multiple institutions. Most healthy patients aren't affected by it. I think but occasionally you'll get, we don't necessarily know how many of our patients develop a pneumonitis or even worse, a pneumonia later from, a silent aspiration or something like that. Yes?
I'd like to make a comment about that. So Dr. Karsten has written a paper recently that's coming out in ANA, and we looked at our experience here using Sugammadex. Sugammadex, we went from neostigmine to Sugammadex in 6 weeks, and within then the period that followed, we had 1 dose of neostigmine given, and that was to show somebody how it worked. That's how good it was. In our organization, it only costs $11 more per patient. But the point is they looked to see what happened with it. And in the period for the next 2 years, there was not an admission to the ICU for respiratory distress, for respiratory issues. And patients, all those patients who had Sugammadex in comparison to the ones before. And I'll let Dr. Bartels be more specific about it. But I think it's an important thing to say, yeah, I think anyone who's used it extensively never wants to go back.
And I think that's an excellent point that it's sometimes hard to make to the pharmacy, that all you need is 1 reintubation, and it pretty much covers the cost of the Sugammadex. And our reintubation rate went down quite a bit when we started using it. And so, I think those papers will come out, the sort of pharmacoeconomic analysis, and the price of Sugammadex has come down. The cost of neostigmine and glycopyrrolate went up, so they're not that different now. And when you think about these pulmonary complications, that's a big factor. Thanks.
What is the latest recommendation for women of childbearing age who use Sugammadex? What do you tell them?
Well, that's a minefield in a way. So we're required to disclose to them that they should use an alternate method of birth control for a week, and there's a form that we're legally supposed to give them. I think you have to decide how important. That might be a case where you would just use neostigmine. Why avoid the complication? Apparently, missing 1 dose can lead to an unintended pregnancy.
Any other questions for Jonathan?
All right, thank you.